folks. Are you seeing my opening slide? Great. Really happy to be here talking about the Crisis Care Clinic at Seattle Children's. I haven't been able to join for the earlier talks and expect there's a lot of overlap and definitely welcome discussion either at the end of my talk or throughout. I tend to be pretty informal, so feel free to jump in if it would be helpful to clarify as we go. I'll trust others to watch the chat maybe more carefully than I can. My name is Eileen Toohey. I'm a clinical psychologist here at Seattle Children's and University of Washington, where I'm an assistant professor. And as Tona introduced, I'm one of the co-leads of the Crisis Care Clinic here at Seattle Children's that's been up and running for a few years now and is one of the many pieces of the various puzzles that we have to take care of kids in mental health crises. Let's see if I can advance slides successfully here. All right. In terms of disclosures, we want to acknowledge that the Crisis Care Clinic was initially set up thanks to an anonymous family donor. Otherwise, we don't have any disclosures. The family that donated money had themselves had the experience of sort of multiple emergency department visits for a child of theirs in a mental health crisis and asked us to work on alternatives to provide just-in-time evidence-based treatment for kids in need. I'm going to pause here and pull up this chat. Great. So I will today be introducing the Crisis Care Clinic model, reviewing some pilot outcome data briefly, spending some time talking about some of the lessons that we've learned in setting up this clinic, and then talk a little bit about future directions. I might zip through a few sections of this, knowing we're late in the day, but again, jump in if people would like clarification about anything as we go. I expect that this audience is familiar already with the rampant need for care for suicidal youth, with suicide as a leading cause of death among 10 to 24-year-olds. It's the second leading cause of death for subsets of that age group, and a 62% increase in suicides from 2007 to 2021. So the devastating impact of this is known. And then in addition to high rates of suicide, we also have a lot of youth who are considering suicide and attempting, both of which are risk factors for eventual completed suicide. This group knows that emergency departments are overburdened. This graphic is a recent snapshot from our emergency department here at Seattle Children's, where the orange bars are patient volumes and the black line is length of stay. And I expect this is, again, well known and probably discussed today, that in addition to higher and higher volumes, kids are getting stuck in the emergency room. I'll also note that the emergency room for many kids is the first place that they have an experience with mental health treatment. And so we want to be both increasing the quality of care that kids are able to receive in the emergency room, but then also quickly connecting them to effective ongoing care so that the experience that children and families have with our mental health systems is positive and feels effective and productive. So as I said, a family donated money a few years back asking us to create an alternative program that would, for some youth in a mental health crisis, improve their experience. And the first step that our group undertook was stakeholder analysis of goals for creating this clinic. So the goals that we were tasked with were addressing the gap in the continuum of care. So knowing that oftentimes kids are accessing outpatient care and they're accessing acute care, but middle levels of treatment are harder to access. Increasing support to parents and other caregivers, knowing that direct support for parents dealing with crises is protective of children's mental health and one of the necessary components. Minimizing wait times, given the crisis nature of the work. This is one of our trickier things. We can talk more about that. And then that this is a brief intervention so that we're able to provide access to more youth. The kind of quicker we can treat people, the more folks we can see, and that our treatments should be lower cost than emergency and inpatient care. And these are the 4 areas that we've really focused on in our crisis care clinic model for suicidal youth. So providing quick access to evidence-based treatment, improving outcomes for patients in a suicidal crisis, helping families navigate systems and connect to services. We know that there are better outcomes for kids who see a mental health provider within 7 days of an acute level treatment, and yet about half of kids who discharge from inpatient care do not connect to folks quickly. So this is one of the primary goals of the CCC. And then managing suicidal crises on an outpatient basis. And this is something we talk about a lot within our own clinic, but then kind of across systems at Seattle Children's, that there's not evidence supportive of inpatient psychiatric care for improving youth suicidality. And most kids who are suicidal can be cared for safely on an outpatient basis, provided appropriate supports. So we stood up our clinic in 2019. It's a brief just-in-time treatment for kids ages 10 to 20 in a suicidal crisis. So far we've seen, this past week we saw our 300th patient, so making good progress in providing care to a lot of youth, but also in some ways a drop in the bucket compared to all of the youth experiencing suicidality. In terms of the structure of our care, we provide up to 4 appointments for both the patient and the caregiver. So it's a concurrent appointment where caregiver meets with one clinician, patient meets with a separate clinician, and then everybody meets together. Most of the families end up using 3 or 4 of those visits. We use CAMS, or the Collaborative Assessment and Management of Suicidality, which I'll talk about more. There's a strong emphasis on case management, knowing that it's like a part-time job, I say to families, navigating our mental health system. So we really want people to have some hand-holding and support, especially because when we're in crisis, we don't have extra bandwidth to handle those sorts of things. And then a large emphasis on connecting to ongoing care. I'll say when we started, I had a worry that we would just end up with these giant caseloads of families who we kept, because we know how hard it is to connect to ongoing care. And thanks to our excellent case managers, we have a lot of success with getting kids connected and moved through our program. We developed some guiding principles for how we talk about suicidality with families that we like to share with families, excuse me, and like to keep in mind. I think those of us who work day in, day out with families in a suicidal crisis can sometimes forget to keep these principles at front of mind. And I think it's important for us to remember, especially for families who are coming to us with a first crisis, that there is a lot of vulnerability in that process and expectations of judgment. So we want to make explicit that we know that this can happen to anybody, that most people who become suicidal do not stay suicidal. We take suicidality very seriously, and a suicide attempt is a major risk factor for suicide. And many kids who have suicide attempts can move on with their lives, and we want to kind of fight the stigmatization and over pathologization, excuse me, of suicide in youth. As I mentioned before, hospitalization is not our first line of response for a youth in suicidal crisis. This is something that I would say 5 years ago when we started talking about this in our system felt like more of a lift in terms of changing perspectives around the rate at which youth were hospitalized. I would say these days, given the crisis and kind of increased learning, more and more folks who I have contact with are comfortable with the concept that we can really take care of suicidal youth at home. And then that families should be included in care, which I've touched on already. So CAMS may be familiar to some folks on the call. I'll run through some of the major components of the Collaborative Assessment and Management of Suicidality. Dave Jobs, who developed this treatment, just came out with the 3rd edition of the treatment manual a few months ago. The philosophy of CAMS care is that you work to develop empathy for suicidal states. So really working to understand the patient's perspective on how it is that they come to think about not wanting to be alive. Emphasis on collaboration in the process, sitting next to the person as you work with them rather than across from them. And then really working towards honesty and demonstrating non-judgment in the care that we provide. CAMS is based around the suicide risk assessment using the SSF or suicide status form, which I'll show in a moment, and we update it every session. And then we use that SSF to develop a treatment plan that is focused on patient-defined drivers of suicide. So the idea here is that if we can work collaboratively and non-judgmentally to understand the individual reasons that the person has to, at times, consider ending their life, we can then develop a treatment plan that really specifically targets those individualized drivers of suicide and thus instill hope and get people connected to the right kind of care for their needs. And then built into CAMS is a disposition plan. So it's meant to be a brief treatment where after 3 consecutive sessions with low risk, CAMS treatment can end, and clinicians can either continue with a different form of treatment or transfer patients on for additional care. Getting trained in CAMS is pretty easy. I should say it's straightforward compared to some of our evidence-based treatments and not too expensive. So it's a good one to know about. This is the suicide status form that I mentioned. This is the initial treatment version where you sit and have the patient hold the pen and you walk through them step by step, completing each of these items, having them do the writing, or via telehealth, you take down exactly what their words are, and use this page to really build that empathy and understanding of what's happening for this person. I will say I had a little skepticism when I first started doing CAMS-based care about how adolescents would respond to kind of a worksheet looking intervention, and my experience has been overwhelmingly that this is pretty accessible for most of the kids who I work with, even kids who are pretty resistant to talking about their emotional experience. I think maybe especially those kids often respond well to these prompts and the ability to really describe their experience. I see that there's something in the chat, and I'm going to just open that for one moment. Yes, it may even be a full-time job. I assume that you're talking, Trevor, about finding mental health care. That's true. Hours and hours spent by our specialized case manager, sometimes for each family who we're connecting to care. I'm going to continue to pause for a moment in case there's any other questions at this point. Okay, keep going. So there's a growing evidence base for CAMS treatment. I'll zip through this a little bit just to say that for adults, CAMS is considered a well-supported intervention thanks to a number of randomized controlled trials. And for youth, there is emerging evidence, including feasibility work, a psychometric evaluation of the SSF with adolescents, and more recently, an open trial demonstrating strong clinical outcomes for youth using CAMS. That trial in 2021 was led by Dr. Molly Adrian here at University of Washington and Seattle Children's. And then moving to the structure of treatment for the crisis care clinic. The tasks that we undertake in working with each of these families for about 4 sessions are to assess safety and teach skills to reduce the likelihood of suicide or self-injury. So we're really suicide focused, to help the family better understand and communicate about suicide. This is a big one, and this one emerged over time. I don't know that we expected to be doing as much family work as we've ended up doing. But very often, one of the things that is not going well for the kids we work with who are suicidal is that they're having a really hard time communicating with the adults in their lives. And sometimes they have a lot of will to communicate about their needs and need some support in how to do that. And it is definitely the case that caregivers need some support in knowing how to respond effectively. And then the third task is to assist families in connecting to recommended ongoing care. So I mentioned we have up to 4 visits that we do co-treatment. The first visit is 90 minutes, the follow-ups are 60 minutes, and we do meet once a week. We had initially thought that we would need to meet more frequently, and we found that families really preferred weekly meetings, and that most of the families we've ended up seeing have been stable enough that weekly visits feel sufficient. And then we have hands-on care navigation, as I've mentioned. We have a full-time case manager who helps families get connected to care, I think the other thing to highlight about having a case manager is that it supports us as clinicians. That I think one of the reasons that outpatient clinicians are hesitant to care for suicidal youth is that it's really hard to do some of the kind of in-between tasks and to sort of hold the anxiety and feeling of responsibility. Whereas when we can share that as a team and really have somebody helping us with things like connecting to the therapist so that we can provide a warm handoff, it makes the work doable. And this is really appreciated, really specialized case management that our team members provide. All right. I'll give a little bit, I won't go through this in great detail, just to say that the first visit is 90 minutes. And the goal is for us to separately gather information from the caregivers and from the patient about suicidality and about their needs. So with the patient using CAMS, with the parents or caregivers using the CAMS parent response form. But then importantly that we come back together at the end. So the two clinicians have a chance to huddle and talk about what they've learned. And then everybody comes together and has a facilitated conversation about what's going to happen during the coming week, and specifically about the safety plan and how that's going to go. I heard a little bit of the end of a prior talk about MI and using safety plans, and we really do get very concrete around sort of the nitty-gritty here. How is this actually going to work? And then revise that each week as we go. People often ask about what we do during the caregiver sessions, and as I think I mentioned, we had not intended to have as much caregiver face time as we do have. These are the steps we go through during the initial session: establishing rapport, assessing the teen's suicide risk from the caregiver perspective, using the CAMS parent response form to get a sense for the parent's own emotional response to their child's suicidality, as well as their sense of kind of efficacy in managing that, so that the clinicians have a sense for what to target for the caregivers. Providing psychoeducation about suicidality. I have so many parents who I work with both in CCC, and then I also work on our consult liaison service, who just have really big questions about, where did this come from? I had no idea. What does this mean? And being able to sit with parents and give them some information and support around that has been really important. And then we really spend some time on lethal means counseling. We've found that it's important for families to, again, get sort of nitty-gritty here and talk about the details of what's needed in order to appropriately restrict access to lethal means, and thinking of that as a pretty individualized approach too, where our recommendations differ based on our assessment of risk and concerns about the child or youth. I can talk more about 1, 2, 3 communication later if people are interested, but this is sort of just a brief tool that we've developed for communicating about safety. We developed it because we learned that a lot of kids, even kids who express feeling really comfortable talking to their caregivers about their safety, struggle to find the words or find themselves up against barriers when in a crisis and needing to communicate that they need help. So we practice and talk through how to use a shorthand to communicate about that. And then here, the return sessions with the caregiver, so the 3 follow-ups are similar. I'll just mention here that we start to introduce evidence-based parenting skills in service of the other treatment tasks. And here we use FAST-P, which first approach skills training for parents. If folks don't know about this, it's available through the Seattle Children's website. The FAST materials address a lot of common youth behavioral health concerns in really straightforward ways that are available to families and developed for primary care. And we've found their parenting teens modules to be very useful for the parents who we work with. So we're weaving in some parenting skills. The big hitter that we use most often is validation. It goes a long way. It's easy to teach, it's hard to fully implement, and we practice that one a lot. But I would recommend this resource to people who are looking for digestible mental health materials for youth. little bit of information about our pilot data. Pretty long pilot. This is clinical data. We kind of got started and up and running, and then did some analyses of our first 189 patients, but wanted to talk about our referral sources. So a large group of the patients who we see come directly from the emergency department, and then a good number come from our consultation liaison team. As I mentioned, I work on that team, and it is a very wonderful thing to be able to see a kid on CL who's had a suicide attempt and to discharge them and know that they'll be seen within a week, and get some evidence-based treatment, suicide-specific care, and then real robust help with getting connected to ongoing care. It's been a game changer in terms of how I feel, honestly, discharging some of these kids. And so we do prioritize kids who we think would otherwise be psychiatrically admitted for their suicidality, which means that a lot of our referrals come from the ED and from inpatient medical. And then half of the kids in this group had attempted suicide during the month prior to treatment. I'll zip through here. Gender and race breakdowns for this subset of kids, and this slide doesn't include ethnicity, but 14% Latinx youth. And then I think I'll also just highlight that we have a fair number of gender nonconforming youth, and we know that that is a group at elevated risk for suicide. Briefly run through some outcomes here. We've seen in this group a significant reduction of self-rated suicide risk among the youth. Of patients who didn't already have an outpatient therapist, and I think a little under half did, 88.5% were connected to a therapist, so had an appointment during the 4 weeks that they were working with us, they were connected to care. Going back to the full-time job comment in the chat, that's actually quite a heavy lift. Hillary, our current case manager, spends a lot of time calling out and really solidifying availability of therapists. And then during the month following discharge, kids who had been connected to novel services by us, 94% reported attending follow-up during that month. During the month following discharge, 12% had visited the ED for a mental health concern, and 8% were psychiatrically admitted. We really need a control group to better understand these numbers and sort of how they would compare to other avenues of care, and we don't have that yet. Really high acceptability and feasibility. I won't go through these in detail, but just that we get a lot of feedback from caregivers and kids that the treatment feels like the right treatment. I keep having to move my Zoom and my slides around here, excuse me. So some comments from families we've worked with. One patient saying it was refreshing not to be sent home and put under surveillance for mentioning suicidal thoughts. We do recommend increased monitoring, but I think this kid felt validated that we're open to talking about suicidality. Another patient saying it made my parents feel better and understand more. Oftentimes one of the things that bugs kids most about being honest about their suicidality is worrying about hurting other people or burdening others. The questions I was asked helped me build an understanding of my emotions and made me feel heard. So that validation piece that we're really hoping for. From caregivers, there was a comment about appreciating the immediate response, getting into an appointment right away. We were able to receive help before things got worse. Having the parents meet separately with a therapist and then getting everyone together to go over what was discussed and to talk about ideas and challenges. And then last one here. I felt very lost after the crisis we had with my child, and these appointments helped to provide me with the tools to make changes. So really hoping to meet families where they are and having some experience of success with that. Wanted to talk a bit about sort of lessons learned and things we've been improving through iterative process improvement, and then things we still sort of need to do. We've worked a lot on our patient flow, so we don't keep a wait list. We only schedule when we have an opening within 7 days. So this means that people get connected quickly when they get connected. It also means that we have to say no if we don't have any openings, and it's a balancing act. a 2 clinician model was not what we set out to do, and it's what we have now. And I don't know that we anticipated how challenging that can be from a scheduling perspective. So that's not the most interesting conversation, but it is something we think about and talk about a lot. Do we need 2 clinicians? It is very helpful in many ways, but it really does create barriers. If somebody's out, all of a sudden you have all these domino effects. Defining our scope over time, I think it's important to note that we've realized that we are most helpful to families who are experiencing a suicidal crisis, usually for the first time, or who are pretty early in their experience of suicidality, and that we aren't as useful to families who have been experiencing chronic suicidality or who really need a higher level of care. So again, this means that we are saying no to some folks who also do need treatment. And then along those lines, we have gotten better and continue to work at communicating with our referral sources about what we do and don't do, and really developing and managing those relationships so that we can have the kind of quick communications that we need in order to support teams like the CL and ED in getting quick answers about who they can connect to us, but also making sure that we're providing accurate information to families about what they'll be receiving. So it's an ongoing process. Things we'd like to learn more about. We don't know much about how our patients do long term. We want to know more about how culturally responsive this approach is, and I think thinking about ways that we can more quickly adapt to families whose cultural identities impact the way that they are experiencing and responding to suicidality. Questions about whether this is the right treatment dose. So this is a treatment that is much less costly and robust than inpatient psych, but quite a bit more costly than regular outpatient treatment, in that we have case management and those kinds of things. So understanding which components of what we do are most needed. And then thinking about how we reach more families. So both families who are further upstream, haven't yet gotten to the point of a suicidal crisis, and families who have more chronic or more intensive needs, knowing that we are really just working with a segment of suicidal youth. So future directions include further evaluating the model against a comparison group, evaluating for cost effectiveness, learning more about long-term outcomes for our patients, ensuring cultural responsivity as well as equitable access to care, and then thinking about outreach. So as I mentioned, many of our referrals are from the ED and from CL, and of course we would hope that we also are able to support kids before they get to acute level services. I imagine that's been a theme today too in some other talks. So with that, I'll say thanks on behalf of our team. This is sort of the original group who put together the crisis care clinic a few years back, and just want to acknowledge Dr. Elizabeth McCauley and Dr. Molly Adrian, who really got the ball rolling and have been leaders in this area for us.
Wow. Thank you, Eileen. Wonderful. It's wonderful. I knew about this program, but not in such depth. And this has been amazing to hear what you're doing. It's just, it just seems like such an efficient, powerful way to deliver care to kids in that sort of interim stage. And, you go. That's what I would.
Thanks. We hope so. It's very fun. It's like a really, I know that may be a strange thing to say, but being able to do team-based work like this it's satisfying, and we meet a lot of really great kids. And I think we often are meeting kids who honestly are sort of at the tail end of their crisis. So it can sometimes be a very hopeful time where we're focusing on getting back into school and into life rather than some other points in the process, which I think can be harder.
Yeah, that's great. That's great. Any questions for Dr. Tui? A couple minutes.
I have a couple.
Besides Chip. No, Chip always. Go ahead, Chip.
I guess I'm wondering how hard it is to connect the kids that need longer term care after, your time frame, and specifically how hard is it to find evidence-based, interventions, and do you favor some DBT, and then it wasn't clear to me, and I've been distracted by something else going on a little bit. So is there a telehealth component to this, or is it strictly, um, you know, kind of the family-based model in person?
Thanks. Yeah, I'll answer the telehealth question first. We can deliver the treatment via telehealth. When possible, we prefer at least the first visit to be in person. That's not possible for some families due to distance or other barriers, so we can definitely do telehealth. We did remain primarily in person throughout the pandemic. I always have to admit to a strong personal preference for in-person work, and then also recognize that we reach more people when we have telehealth options as well. But I think most of our clinicians, and honestly most of our families, express a preference for in-person, given kind of the nature of what we're talking about, as well as the sort of moving pieces of going to separate rooms, if that makes sense. So both are possible. And then the question about how challenging it is to connect people to ongoing care. It's very challenging. And I think reflecting over the years of this, I would say in earlier years, I was probably more specific in my requests to our case manager about what type of care we're connecting kids to. So really things like DBT and other evidence-based treatments, sort of expecting that that is what we would get them connected to. We still do, and I think I've noticed a drift in my own hopefulness about the kind of evidence-based quality of care that we're able to access. It's just so much harder to access anything these days that I feel I can't be as specific in my requests. And so we're connecting kids with therapists. We're really prioritizing evidence-based treatments. DBT is one that we often are really hoping to get kids connected to, but we don't know much about long-term the quality of care that they're receiving and how effective it is in addressing their needs.
Thank you. Vicki, I want to circle back to you. You had a question in chat. I want to make sure whether you got that answered or not. And Eileen, it was...
I think mine was answered. Eileen, it's mainly a referral-based service. I mean, people can't self-refer. Is that correct? You're a referral-based service.
You know, they actually can self-refer. So anyone can refer, but we don't keep a wait list. So the way that that ends up working out is that whether or not you get a slot depends on who was referred that week and kind of how you are triaged within that group. And typically that means that the kids who are in the ED and the kids who are on the medical floors rise to the top of the group because we're prioritizing the kids who we think might otherwise be hospitalized, if that makes sense. So we've toyed with that over time, and I'd love it if we had more options that people could self-refer to, again, in the spirit of catching things upstream before they get to the point of a higher level crisis. I can clarify that more if it would be helpful, but anyone can refer, and then we triage amongst the group that we get each week.
Yeah, it's all kinds of difficult choices in the milieu of lots of patients to see, but no, thank you. Go ahead, Chip.
I guess my other one is, and I don't mean this to be confrontational, but it's Chip, so I have to say something. I'm trying to understand the connection between what Dr. Enriquez showed today with, I think, 18 kids boarding in the ED at Seattle Children's and the availability of your program. What's missing so that those kids aren't boarding and they're in CAMS?
It's a great question, and not taken as confrontational. And to be honest, I don't know for sure. My expectation is that the kids boarding in the ED are likely more complex in their needs than the kids who were taking in CCC. So we're often reviewing the list of kids boarding in the ED and going, could any of these kids get in here and get home from the ED? And that happens sometimes. And more typically, I think the kids who are boarding are needing something that is more robust than what we offer. And now I see others coming on to address the question as well.
Yeah, Chip, I was just thinking about that because of course it's hard to hear about these resources, but I know that a lot of patients do come from the emergency department to go there, but I think it's purely acuity. The acuity is so high that the patients in the ED that are boarding currently, I was just literally looking at the list a moment ago, you know, we can't even put them up on kind of an inpatient unit to sleep and get programming during the day. There's just very limited options for the acuity that we're seeing right now. So I think that would be the answer, unfortunately. Just exceeds the resources.
Not quite ready for therapy, it sounds like.
Yeah, and a high percentage of them really are well, I would say a certain percentage of them are aggressive and have other behavioral issues than suicidality as well. So it doesn't really match this program. So it's a kind of we have other outpatient programs that address those as well. But there's like Eileen was saying, there is a jigsaw puzzle of resources that I still struggle to understand. But I'm pretty confident that every day our mental health colleagues are running those lists and looking at those patients and trying to prioritize them for any kind of outpatient resources they have. It's just I don't think they fit those resources, unfortunately.
Can I ask one more?
Fine with me.
It's actually for Dr. Enriquez.
then
I think you've been with us for many hours today. Have you heard anything today that could apply to those 18 kids or whatever, the ones that are the high acuity that you've got boarding? Do we give you any solution pathways?
Well, I can't. First of all, I've been on and off because I've been doing multitasking quite a bit today. But you know, I think that a lot of these resources that are provided today are going to be incredibly helpful to the hospitals that are seeing kind of these lower acuity kids in the community that need help and need resources and can't find them on their own. I think, you know, I think that that's where a lot of work is geared towards, is kind of this outpatient realm. I think, unfortunately, I mean, at least what we need, and others can from other areas in the country can speak up, is we need more inpatient spaces that are safe for these kids, that can keep them safe while they're being treated and getting stabilized. And those are the patients I'm seeing the most. I can tell you that there's a lot of kids who come in and we are able to connect them with outpatient resources, and those are successes, but there's just a lot more that won't be enough for. And then of course there are, and I can't speak to this very well because this would be more for my mental health colleagues on inpatient. There are a number of patients who don't meet criteria for hospitalization, but have nowhere else to go. And that's a whole different conversation.
I see one more question from Dr. Sakata, and then maybe some kind of summary comments from Dr. Schreiber.
Hey, thanks. Oh yeah, okay, I'm off mute. Hey, I would just also add to Chip, your comment. Oh, can you guys hear me? Yeah, okay. Case in fact, like how many of these resources that we heard today are going to help Dr. Enriquez with those 18 patients? And I would agree with Bree that, you know, probably the patients that are in a specialized pediatric institution, that a lot of these resources won't be as helpful. But I would just like to say personally that the resources that you guys have brought forward in all of this, all of your work that people have presented today, is really going to help those community providers, those community health providers. And there's so many of these smaller community hospitals and more rural communities that they just need a handful of tools to help them de-escalate, to help them hopefully provide outpatient treatment before patients get to this point of needing the Seattle Children's of the world or the Cincinnati Children's of the world. I think that's where the hope lies primarily. And I'm hoping that's where the hope lies primarily. I mean, we're in the thick of this huge crisis where kids are just, you know, at such a state of mental crisis that it's really hard to come up with those resources. But my hope is that all this work that you all are doing is going to empower so many other specialties that have outreach to these children, from school teachers on down to, church counselors. I don't know. Everybody has to be part of the solution here. And that's why I believe that, all the work that you, Chip, and Tona, and Rapam, and everyone who's working on this, everybody who's been on this call, it's been so fundamentally important to get those resources out there. So I'm just saying thank you to all of you. And I'm sorry, Bree, that we can't help your 18 people, but I'm hoping we've helped 100 other children that are maybe, starting to escalate at home right now, and we can prevent them from needing to need a Dr. Enriquez or a Dr. Tui, so that we can really help the kids the most before they escalate. Anyway, end of my soapbox. Over.
I feel much better. Thank you. That was a very aspirational statement, but I do agree that if we can spread the wealth a little bit to other places in the community, it's ultimately going to help places like Seattle Children's and other children's hospitals that are inundated right now. It's that whole triangle thing. So I want to thank everybody who has hung in there. I know people have come and people have gone. I think at least for me, it's been amazing to hear what's going on out there. You all, anybody who's registered will get access to the recordings, which I think we're hoping to break down into individual recordings. So if you want to hear what Dr. Tui has to say, you can go straight to her video, or Dr. Enriquez, whoever. And then all of the resources, and we've been gathering additional as we've been through this webinar today. You'll also get access to all of those. Thank you all. I'm going to turn over to Chip for last comments and then give you what's left of your afternoon.
Or evening, depending on where you are. I just wanted to also thank everyone in our team, Trevor, Tona, and Kara, for putting this together. It was an incredible logistical effort. And to all our guest speakers from around the U.S. that gave of their time and energy and insights. I think it's just a lot to distill. I think we kind of kicked off with kind of the national perspective with Kate and Mo and some of the national efforts, the very high level policy statement that Mo worked on for years and years to get a joint statement out of AAP and ACEP, I think is no easy feat, and he pulled that off. And then we learned a lot about situational awareness, actually with Dr. Enriquez and the dashboard, and Dr. Sakata, the effort in Washington State, kind of pioneering that. The telehealth, the incredible tribal model that Dr. Dial shared with us, where they don't have a boarding issue as they once did. The cultural appropriateness of the provider match, the breadth of the resources, the funding to create behavioral health capability in integrated care settings, preventing, worsening over time, how they've managed their own after-hours crises, their link to 988, and to even how they engage when kids do end up in the ED or inpatient units, and how they manage that transition back to their own community. The school piece we heard, the incredible community collaboration model also at Marybridge we heard about. I think there's an incredible amount to learn. Some of the research, the ED Safe 2 study out of UMass, where they've actually shown decrease in completed suicide rates as a function of their ED intervention model. I mean, that's a pretty impressive dependent variable death, and they've been able to demonstrate that. I think it'd be wonderful if we were able to do similar things in the pediatric realm. And I know I'm interested in, it's not my area, but trying to facilitate that so that we have that same kind of growing evidence base for kids as we do for adults. So those are my thoughts. We will be thinking about how we can continue to facilitate, everyone's effort toward moving the ball further down the road. So don't be surprised if you hear more from us. and certainly when the recording links are available. And know that we stand ready to try to add what we can to the complexity of this problem. We're so very energized, at least I am, by all of the folks around the U.S. doing such incredible work for kids and concern and compassion along with it. So thank you all. Hats off to all of you.